With this video, we're going to get into a deeper understanding of test characteristics. Now, let's get into a deeper conceptualization of test characteristics. We know that, unfortunately, there's no such thing as a perfect test. So how do we navigate test results if we know they aren't perfect? Well, first we have to understand that there's 4 possible outcomes for a test. Number 1, we can get a true positive result, meaning the test is positive in a patient who truly has that disease. It helps us diagnose that disease or rule it in. 2, we can receive a false positive result, meaning the test is positive in a patient who does not have that disease. In other words, it can lead us down a rabbit hole of possibly more investigations, patient anxiety, and improper treatment. 3rd, we can receive a true negative result, meaning the test is negative in a patient who does not have that disease. It helps us eliminate the possibility of that disease or rules it out. 4th, we can have a false negative result, meaning the test is negative in a patient who actually has that disease. It gives us the false impression that that patient is disease-free, which can lead to morbidity and mortality, delayed treatment, etc. Commonly used test metrics are things like sensitivity, specificity, positive and negative predictive values, and likelihood ratios in medicine. More on this later in the course. We use these test characteristics to identify the most likely diagnoses for our patients, but interpreting these metrics have many pitfalls. Now, how we generate these test metrics, how accurate or inaccurate, helpful or unhelpful these tests are, is done through research. And these research studies are done on particular cohorts of people in the population, sometimes small cohorts, that don't represent the full population or the patient that you're seeing in your own practice environment. So this emphasizes the point that there's no such thing as a perfect test. In other words, we can't take test results at face value all the time. So just because a test is positive or negative, normal or abnormal, doesn't mean it'll actually help you get to that correct diagnosis. We have to interpret the test results within the patient's context. We have to think of unique patient characteristics, prevalence of disease, and whether that result fits the entire clinical picture, whether it fits the entire assessment that you just did on that patient. Let's illustrate with a few cases. So first case we're seeing is a female coming in with a history of gestational diabetes, increased thirst, hunger, and fatigue. We go ahead and order a hemoglobin A1C as part of the workup because we're worried about diabetes. The result, A1C of 10%. So now we ask, the result's positive, does it make sense? What does this mean for my patient? Have I actually ruled in diabetes? So in this case, an A1C of 10% makes sense clinically. Diabetes is a common condition, she has a risk factor, the gestational diabetes, and she has symptoms of what sounds like decompensated diabetes with the increased hunger and thirst. So we can trust that this is a true positive result. We're thinking about that unique features of the case and whether that test result correlates clinically. Now let's contrast with a different case. Let's say a healthy young patient comes in with a stub toe, and by accident a hemoglobin A1C, which screens for diabetes, is ordered. The results come back at 8%. Now we have to stop and pause, asking ourselves, what does this mean? Does it make sense for the case? Is this a true positive result or is it a false positive result? I can't discard the results, but it would make me stop to pause. Now I need to retest that patient. In other words, we can't take that test result at face value. We have to stop and pause and ask ourselves, does this result make sense as it relates to the patient in front of me? These cases allude to the important concept of positive and negative predictive values, which we'll get into later in the course. Here's another point. Not all tests are created equal. Given that tests have different characteristics, some being better, some being worse at testing for diseases, this means that some tests we apply to a case will have a different impact on the diagnosis. Some findings are much less specific for a disease and don't change your diagnostic interpretation that much, but other tests are way more specific and will change your diagnostic interpretation a lot. So it's important that we don't treat all tests as having the same impact or weight on a case. We also have the really tough task of weeding out irrelevant versus relevant information from the case. This is probably the hardest part of any assessment. Let's go through an example to hammer out these concepts.